Okay, well, let's get started. A lot of people are signing on right now, and I'm sure some more will be joining us shortly. But on behalf of the Global Surgery Foundation and United Nations Institute for Training and Research, I'd like to welcome everyone to this next edition of the NSOAP series, focusing on the NSOAP manual. And today we have a great session with an amazing lineup of speakers and moderators, and looking at the role of NGOs, professional societies, and academic centers in how we can promote the NSOAP process to increase capacity in surgical care. So I don't want to take up too much time at the beginning here, and I just want to thank Johnson & Johnson, our major sponsor for this series, and our co-hosts today, SmileTrain, WFSA, and FIGO, and of course, the Program of Global Surgery and Social Change. And on that note, I want to turn it over now to Scott Corlew, a plastic surgeon at the PGSSC, to just make a few comments, and then he will then turn it over to our moderators and introduce them. Thank you very much, Scott. The floor is yours.
Thanks, Jeff. Thanks to everyone for attending. And I hope that many of you have had the opportunity to attend this entire series. This has been a joint effort of UNITAR and the Program for Global Surgery and Social Change, focusing on the concept of national surgical obstetric and anesthesia plans. This concept, of course, was an outgrowth of the Lancet Commission on Global Surgery and is arguably the best framework for countries to develop appropriate surgical care within their national health plans. This series has covered key aspects of this framework, including NSOAPs in the pandemic response, donor perspectives on funding of surgical care, customization of the framework to individual country needs, and today, as Jeff just said, the role of NGOs, academic institutions, and professional associations in surgical care on a national scale. UNITAR and PGSSC are honored to have the sponsorship of Johnson & Johnson, the SmileTrain, and the World Federation of Societies of Anesthesiologists, as well as FIGO, and privileged to have today's webinar moderated by Aaron Stieber of the SmileTrain and Dr. Adrian Gelb of the WFSA. And with that, I'll turn it over to you two, Aaron and Adrian.
Super. Thank you so much, Dr. Corlew. Great to see you and great to be here with everyone. We're excited for a really engaging discussion. We have a number of fantastic panelists with great representation across academia, professional organizations, and the NGO space. So I'll very briefly introduce myself and then let the panelists briefly introduce themselves, and then we'll circle back to get into the discussion with some more specifics about how these groups have been engaging and what the opportunities are for the future. So I am Aaron Stieber. I am not the president of the ASA or board member of the WFSA. I'm the senior vice president of programs at SmileTrain, and I'll turn it over to Adrian.
Thanks, Aaron. We love you and would love to have you as a member. Just a small little glitch. We'll need to send you to medical school first.
Exactly.
I'm Adrian Gelb. I'm an anesthesiologist at the University of California, San Francisco, and president of the World Federation of Societies of Anesthesiologists. And I too welcome you. Looking forward to a very informative and exciting discussion. And also want to thank PGSSC, the UNITAR, and Johnson & Johnson for putting all of this together.
Fabulous. Well, we wanted to give all of our fantastic panelists, it's going to be more of a discussion, I think, than a panel today, but just the opportunity to briefly introduce themselves, and then we'll go back around and dig into the discussion a bit more. So, Dr. Bekele, if we can start with you.
Thank you, Erin. Good morning, good afternoon, everyone. My name is Abebe. I currently serve as the Deputy Vice Chancellor of Academic and Research Affairs at the University of Global Health Equity in Rwanda. And I think I am in this panel based on my role in Ethiopia as Senior Advisor to the Ministry of Health, when Ethiopia rolled its National Surgical Obstetric and Anesthesia Plan. Thank you very much for the invitation.
Fantastic. Thank you so much. Dr. Catherine Shu.
Good morning and good afternoon, everyone, and thanks very much to our co-hosts and our co-sponsors. My name is Catherine Chu. I'm a general and colorectal surgeon, and I'm the director for the Center for Global Surgery at Stellenbosch University in South Africa. And I lead the finance stream on the South African NSOAP Planning Committee.
Super, thank you so much. Dr. Faisal Kak? I think you're still muted, sir.
Unmute myself. Okay. Hello, everyone. I am Faisal, the Vice President of the International Federation of Gynecology Obstetrics, FIGO. I'm also a senior lecturer and the clinical associate at the American University of Beirut Medical Center and the director of the Women Integrated Sexual Health Program at the Department of OBGYN. I'm glad to be here, and I want to thank on the behalf of FIGO and on my behalf, UNITAR, the program in global surgery, the WFSA for reaching out to FIGO and working together to engage the community of OBGYN in this initiative and this task. Thank you.
Thanks so much. Dr. Bowers, Dr. Alban Bowers. I think you're also currently muted.
Okay. Yeah, thanks very much. My name is Alban Bowers. I'd like to thank everybody for inviting me to join this prestigious talk. I'm the current president of the Surgical Society of Zimbabwe, so I represent about 200 surgeons in the country, including trainees. I'm an orthopedic consultant surgeon working in Harare in Zimbabwe.
Wonderful, thanks so much. Dr. Mauricio Vasco.
Greetings from Medellin in Latin America. Erin and Adrian, thank you so much. I'm grateful to the organizing committee for the invitation to this webinar. I hope to share with you some experience as a member of academic institutions and professional associations. My background is in obstetric anesthesia and clinical simulation. Actually, I am member of the council of the WFSA and the president of the Colombian Society of Anesthesia. My work is in academic in CES University in Medellin, Colombia.
Wonderful, thank you. Dr. Kokila Laku.
Okay, hello, I'm Kokila Laku. I'm a pediatric surgeon in Oxford, and I'm representing GIGS, which stands for the Global Surgery, Global Initiative for Children's Surgery. And I'm here on the panel to represent children's surgery.
Thanks so much. And Dr. Shrestha, Anil Shuster.
Good evening and good morning and hello to everybody. I'm Anil Shuster, representing I think the NGO sector. I'm the only person from the NGO sector, I guess. Presently, I'm the executive director of Nick Simons Institute. I've been involved with the NGO sector since the last 25 years. As an orthopedic surgeon, I helped to establish a not-for-profit 100-bedded orthopedic hospital in Nepal through the help of Rotary clubs in Nepal, and I'm very glad to share my experience in the role of NGOs in the development of NSOAP.
Wonderful, thanks so much. And I'm happy to help co-represent the NGO sector. And I think GIGS is actually a registered NGO as well. So hopefully we'll be able to give a few different perspectives there, but yours will certainly be wonderful. Adrian, I think we were going to provide a brief overview, you and I, of why we might be qualified to participate in this panel, the work our organizations have done and NSOAPs, and then ask the same of the panelists. So I don't know if you want to go first.
Sure, I'd be happy to do that, Aaron. And on the point of who's an NGO and who isn't, I think most of the panelists represent various constituencies, academia, professional organizations. And so in this initial round, it would be useful if you do explain that. The World Federation of Societies of Anesthesiologists is a global federation of 135 national anesthesia societies representing about 150 countries. And the reason we represent more countries than national societies is some small countries have banded together to form a single entity. For example, Pacific Islands are a single national anesthesia society, but encompass about 10 or 12 independent countries. Our vision, our mission is fairly simple: uniting anesthesiologists around the world to ensure universal access to safe anesthesia and perioperative medicine. And we do that always in conjunction with our national societies. So we see our role in NSOAPs as working with national societies, not independently, and using, for example, our status as an official organization in relations with the WHO, of leveraging that to try and connect with ministries of health. Similarly, with our association with UNITAR, using that to get at the highest level of the NSOAP process, and at the other end, using the strength of national societies to engage the on-the-ground providers. And we strengthen the process by providing some tools. For example, the anesthetic facility assessment tool, which can be used as part of the NSOAP process. And then we can tailor educational programs to fit with what the NSOAP needs in terms of care provision. Over to you, Erin.
Super, thank you, Adrian. As I mentioned, I'm with Smile Train, an international NGO active in more than 70 countries, and our passion is ensuring that every child born with a cleft, no matter where in the world, has access to safe and high quality surgical care. We're working mostly with pediatric surgery, obviously, but our model is one founded on empowerment. For the 20 years that we've been in existence, our goal has really been to strengthen the local systems, to empower the local providers, and to make sure that they have the support they need to provide the highest and safest quality care. So we're really excited about the work that's been happening here with the NSOAPs. My team around the world has been quite involved, particularly in Africa, in particular with the Kenya, Nigeria, and SADC regions as they work through their NSOAPs. A number of my Nigerian colleagues weren't able to join today because they're actually in a meeting right now about the NSOAP. So the work is still continuing, but we've been, between our staff and our partners, have been actively engaged in the planning processes as technical advisors, being part of the calls for NSOAPs to be developed, supporting at times financially, and helping to really integrate our programs in capacity building and treatment. You know, the ministries are obviously going to own these, but the NGOs and our partners around the world are have been providing the care, are currently providing the care, and will be providing a lot of the care alongside the government as the plans are implemented. So I think there's an exciting role there. So I promise, Adrian and I are going to ultimately go back and forth and ask a number of questions. So I promise I won't talk too much more, but I wanted to go through again to our panelists and ask each of you to, you know, briefly tell us about the perspective you're coming from, what your experience has been in the NSOAP development process, and what NSOAPs are ongoing in your region. So I'll start with Dr. Shrestha this time. Oh, you're on mute, sir.
Thank you, Erin. First, let me tell you a bit about Nepal and my work. I was involved, like I said, in establishing an orthopedic hospital in Nepal. So that was a total, let's say, orthopedic hospital out of the government. So I was there for 20 years and it was going on well. So it's an orthopedic hospital. But lately, since the last 5 years, I've been involved with Nick Salmon's Institute as the executive director. And the change that I saw there was what we were doing at NSI. We are called NSI in Nepal. What NSI was doing was, it was working with the government only. Yeah, and that too, more on the surgical care and essential surgical care, especially on safe motherhood and all that. And I realized that I thought I was doing a great job in the past 20 years when I was at the orthopedic hospital. But then I realized that working with the government is the answer in a country like ours, where if you work with the government, then only we can do something. And when I was there, I didn't know anything about NSOAP, hadn't heard of it. But in 2017, when I was in the WHO assembly in 2017, that's when I heard first about NSOAP. I was really excited because what they were talking was exactly what we at NSI were doing. We had taken up around 18 district hospitals across the country, working with the government hospitals and trying to strengthen their essential surgical care. That too, because of the fact that none of the orthopedic surgeons, general surgeons, OBGYNs, anesthesiologists were going to the rural areas, then we had produced cadres like anesthesia assistant. They were non-physician anesthetists. We developed the course and they were being placed in these hospitals. That's what NSOAP was talking about also. Then we got hold of the general practitioners where they could perform surgeries like C-sections and appendectomy and all that. So I think that's when we really started thinking about NSOAP. And with all that, then I went to PGSSC and give a talk about what we were doing. And then this March, we were supposed to have a workshop in Nepal, the NSOAP implementing workshop. But unfortunately, due to the pandemic, we couldn't do that. And let's see, I think we could do it sometime next year. But what I see is basically, as an NGO, if we align ourselves with the government plan and not like I did 20 years ago, having a separate hospital, I think we can achieve more. And that's what NSI has been doing. And now we've gone across to around half the district hospitals in Nepal, and they've been providing what we are talking on NSOAP. So I think basically what I'd like to emphasize is if NGOs align ourselves with the government policies and their plan, I think we can achieve more. Thank you.
Wonderful. Thanks so much. Dr. Lakou?
Yes, so I'll start off firstly that the Lancet Commission in 2015 put surgery onto the map as a global phenomena, but they forgot about the children. So in 2016, the Global Initiative of Children's Surgery was formed to be inclusive of surgeons, anesthetists, nurses, allied health workers, and NGOs like yourselves and Kids OR and Operation Smile and so forth. But as things have moved on from the Lancet Commission to the NSOAPs, almost every NSOAP has forgotten children. And it took, even in Nigeria, where the lead for NSOAPs was a pediatric surgeon, he's had just a lot of trouble trying to enforce that children make up almost 50% of the world's population. They are the future and they keep getting forgotten. And similarly in Pakistan, it had been an uphill battle. So I think my message basically is that for whatever we are all doing towards a common purpose, don't forget the children.
Super. Thank you, Dr. Lakou. Very clear message. Dr. Vasco, Marcio?
Yes. Okay. I think that fundamental point in the NSOAP process is to draw the baseline from the surgical anesthetic and obstetric healthcare system using the LCOGS indicators. Latin America is a region who has a model of surgical care surgical care based on specialist doctors. And the countries on these regions have varied degrees of needs, with the majority of human resources and infrastructures concentrated in larger cities. We have a lot of problem geographic barriers. We have jungles, mountains, deserts. We have problems with safety issues, drug trafficking and guerrillas. And in transportation, we don't have airplanes routinary, no boats, and not enough ambulance. That is the reason because we work in the LCOGS in Latin America. Brazil and Colombia now has upper middle income countries who has these indicators. And I think that this is the most important point, have the baseline. And for the future, we try to put this work in the National Program on Health with Minister of Health and try to run the NSOAPs in the regional way, because we have regions we really need it, but we have other regions in the country that they maybe don't need that kind of approach.
Fabulous.
Thank you, Ari.
Thank you so much. Dr. Bowers?
So I represent the Surgical Society of Zimbabwe, and before that, the Orthopedic Society in this country. So basically, Zimbabwe is a typical low medium income country with a population of about 14 million, and typically with a very low specialist workforce ratio. So I was introduced to NSOAP about 2 years ago. At one of our surgical meetings, we had representation from surrounding countries who had begun the process, in particular Zambia and Tanzania. And I've noticed since then Rwanda, Nigeria, Ethiopia, and Madagascar, as well as Senegal, in this region have been beginning to implement this program. So looking at the program, it's an ideal program for our country. So we discussed it in detail at our surgical meeting, and subsequently we approached the other three important pillars: the obstetrician and gynecologists, and as well as our anesthetic colleagues. And in addition, had a meeting with the Ministry of Health. So we're quite early in the process of NSOAP. The initial discussions have been pursued, and there was a general consensus that this is an appropriate program for our country. Unfortunately, we lost a lot of focus from the Ministry of Health, who are meant to lead this, mainly because soon after this meeting, the COVID pandemic started. And clearly for a low medium income country where the pandemic can have disastrous consequences due to a lack of facilities, the government has been more focused on that. Fortunately, like most of the sub-Saharan African region, the COVID burden has been remarkably low, and our facilities have not been overcome. So it will be important once the COVID pandemic is put to rest, for want of a better term, then we can refocus on the NSOAP program. I think the three associations that I represent, one of them are extremely enthusiastic about this program. Although we are in small numbers compared to European countries, I do represent a highly enthusiastic society, and we're looking forward to pursuing this in the second quarter of next year.
Fantastic.
Thank you.
Thank you. Thank you so much. Dr. Faisal Kak, representing FIGO. You're muted, Dr. Koch.
Thank you very much. Yeah, you know, FIGO is a federation that includes 132 national societies in 132 countries, from high income to low middle income countries. And definitely FIGO has more than 1.5 million OBGYNs that we like to think of as foot on the ground. So, and our primary concern remains maternal health and the whole burden of maternal mortality and morbidity related to that. Definitely the GYN cancers and the consequences of sometimes inadequate GYN cancer surgeries, and also the surgical management of many obstetrical problems like the placental accreta pericreta, what we call the PAS, and also, of course, the postpartum hemorrhage. We are definitely, I attended as a VP FIGO and also in my own capacity in the Dubai meeting. It was an excellent meeting. I had a chance to present. And definitely, we are thinking also of this panel and of this activity as a probing activity whereby we're willing to engage all our members in the obstetrical aspects, of course, and the surgical aspects of the NSOAP. We have an excellent record of fistula training. We had more than close by now, I think, to 9,000 fistulas, training people in 19 countries. You know, fistula in Africa is one of the most dramatic and sad consequences of surgery. In addition to the other aspects that I have mentioned, we look forward for that. I think we can join a lot of efforts, especially in places where they don't have the OB as the primary care physician, sometimes the surgeon, sometimes they work together in many countries and the places. And I think it's always a great opportunity when agencies join hands to promote maternal health, women's health, and also to reduce damage and bad consequences. And here we are in good faith, looking forward to work together on these NSOAP initiatives.
Wonderful. Thank you so much. Dr. Chu?
Thanks. So I think I'm on the panel, given the role I play as the director of one of the Centers for Global Surgery, an academic institution here in South Africa. And so to give a bit of a background, South Africa is an upper middle income country. We have one of the greatest health inequities in terms of care between the private and the public sectors. And in 2015, after the Lancet Commission on Global Surgery, there was a lot of excitement here. And in that same year, we had like a NSOAP conference, if you will, that convened the Minister of Health, the Minister of Finance, which is our Treasury. John Mira from Harvard's PGSSC came out, one of the authors of the Lancet Commission on Global Surgery paper came out, and there was just a lot of positivity around it. But it took now 5 years later to finally assemble a planning committee or an NSOAP task team. So at least we have that, and so for that we're very, very pleased. In terms of how academic institutions can play a role here in South Africa is, first of all, there are 3 centers for global surgery, but there are 7 universities, all who are involved on this NSOAP task team here in South Africa. And so the academic institutions are quite involved in the writing of the NSOAP plan. I think specifically Stellenbosch, my institution, the things that we've been doing to contribute to the NSOAP process is first to provide the baseline data on surgical capacity, particularly in district hospitals. So I think a lot of unknowns of what kind of capacity do we already have, and what are the gaps and barriers before trying to write an NSOAP plan. We're also doing research on workforce density, 2-hour access, catastrophic health expenditure, some of the other Lancet indicators. And also we're particularly interested in identifying telemedicine solutions that might leapfrog some of the technology that we don't have here to overcome some of the barriers, like having specialists at the rural hospitals where they can't get to and where we just don't have enough staff. So we're looking into that. I think also the role of academic institutions is just to promote awareness among the local professional groups. So even though global surgery has had, just as a wonderful uptake globally, especially in the high income country forums, locally here in South Africa, where we have huge inequities in surgical access, it's not really a known thing of what global surgery is. So just raising awareness. So now I'm the global surgery representative in the Association of Surgeons in South Africa, for example, one of our professional groups, and some of the leaders in the other centers for global surgery here in South Africa also sit representing their professional groups. So I think for us that's been quite important. One of the other things is that to find innovative financing for our NSOAP. So trying to speak to Treasury about is there any ring-fenced money for the NSOAP here in South Africa. And then what we've been doing is also providing a COVID risk calculator. So we here in South Africa have more than 50% of the COVID cases on the African continent. And our elective surgery, like in most places, was cut almost down to nothing. And now we're trying to slowly come back to it. And there have been other risk calculators created by American groups, British groups that don't really fit our setting. And so we've created one ourselves. And then finally, I think what academic institutions like ourselves can do is really provide a forum for Southern African countries in our region to come together and talk about challenges and share successes about NSOAP planning. So this year in January, we hosted what we called AfroSurge, which we hosted folks from their NSOAP planning committees from Namibia, Botswana, Zambia, Malawi, and Zimbabwe. And I guess just to say for the way forward for us, that the buy-in from the government in the NSOAP planning process is still a challenge. They are permissive, but not really leading the way. And I think that as academic institutions, we're trying to work with our health economists to make the investment case so that the Treasury will actually allocate money to surgery. And I think the third thing is to mobilize the community. Really, it's an untapped resource to speak to the people, not just talk amongst ourselves as professional groups, because we all know how important surgery is, but to get the community behind us. And then finally, to gain more support with the public health and family physician colleagues, because I think they're the ones that are really going to make this part of national health priority. Thank you.
Right. Thanks so much. And Dr. Abebe?
Thank you, Irene. My involvement with NSOAPs began in 2014 when Ethiopia was in the process of drafting its NSOAPs. I was Dean of the School of Medicine in Addis Ababa then. I worked with the Minister of Health, who was in fact a champion for the development of the NSOAPs in Ethiopia. After that, in 2017, when I left office, I was asked to join the ministry as his advisor in this in the implementation of the NSOAPs process. My responsibility also included liaising between our partners such as the PGSSC, JPIGO, ASSIST, the different surgical associations like the Surgeons Association, the Anesthesia Association, Anesthesiology Association, and the different universities. I came to Rwanda in 2018, and the Ethiopian NSOAPs is now almost 5 years old. The country is doing its end of NSOAPs program evaluation. The two things I can say with regards to NSOAPs is that NSOAPs need a champion. Not everyone can do it. Not everyone shares the same enthusiasm from the ministry. Unfortunately, surgery and anesthesia care is still relegated to non-priority in the region, despite all the talk about global surgery, about the financial risks, the unmet burden, everything. It's still not given due attention. And recent changes in the globe did not do us any favors. COVID is a good example. It completely took us back to where we were in 2015. The NSOAPs and surgical planning is completely relegated. So NSOAPs need a champion. Luckily, Ethiopia had the former minister who took this as his personal goal. And the NSOAPs process was called the national flagship project of the Ministry of Health. That was why it grew. And the second thing is East Africa and most parts of East and Central Africa share this unique feature. Surgeons and professionals in the academic institutions are the same ones you find in the association, because we are just a few. We are just a handful of professionals in the country. So we should not be surprised if you find me as Dean of the School of Medicine, Secretary of the Surgical Society, and advisor to the ministry. It's like this in most African countries. So all surgeons, all professionals need to be part of the process. If one feels neglected, not part of this process, the outcome will not be as good as you think it would be. Thank you.
Yeah. Thank you so much.
I was going to just jump in there, and the intent isn't to deprive anybody of their opportunity to speak to the topic, but the discussion has been quite broad in the responses in what organizations have done and can do. And I think the learning opportunity for the 1,000 or more who are joining us is that these illustrate the many different ways in which one can initiate, foster, and facilitate an NSOAP. I want to perhaps dig a little deeper into some of those themes as we continue on, given that we wear many different hats, each of us, both in academia, professional societies, and the like, is to perhaps view the question in a negative sense for the next little round of discussions. What are not the roles that academic institutions, NGOs, professional societies should get involved in? What are the big, deep, dark holes that we shouldn't try and step into, that perhaps from your experience, knowledge, people have tried to do? So I'm going to pick up with the speakers who didn't speak to the previous question and ask them to continue the discussion from that perspective. And I'm going to start with Kokila. As an academic, as a surgeon, as a participant and a leader in an NGO, what are the areas or strategies that you think are inappropriate for that type of organization?
Okay, I think I'll answer this question first, picking up on what Dr. Abebe has said, that in low and middle income countries, you carry many hats. So for that perspective, it's sometimes an advantage in that you can see the perspective of what is important and what isn't. But where problems are rising is that when academic institutions see this as a study, well, it is appropriate to see it as a study, but who is involved in it? So I have great worries about major academic institutions from the high-income countries having a thought process that they know how to do it. The funding comes to them, the thought process comes to them, but people from the areas that they want to study are not being engaged. And a simple fact is the high-income countries get national funding to do global work. What percentage of that funding actually goes to the countries that they are studying? And I can tell you in most situations, it's less than 2%. So I think we need to start rethinking that where does the paradigm lie? Was it with the high-income countries who for years and years and years have been dictating on many fronts? And there's lots of talks at the moment about colonizations and those issues. But similarly, when people with NGOs go with an answer to say, look, I'm going to cure all the club feet in Zimbabwe, without knowing who is dealing with the club feet, who are the people to talk to, because your ideas coming from the high-income country with the funding, you don't know what's happening on the ground. And a lot of the times in our low and middle income countries, people don't speak up at platforms. They are resistant to speak up because the language medium is English and people from high income country have a command of the language. So they just draw back. So those are just two factors. I've just touched on NGOs, I've just touched on academia, but similarly, kind of mission institutions, again, go out there without the knowledge of what is really needed. And another sector is disaster planning. In countries, in low-income countries, when disasters do take place, the assistance from high-income country comes 48 hours later when everything is done and dusted. And instead of engaging with the local team to help with the reconstruction, people go out there thinking they know how to manage the disaster. And the one disaster has led to a wider disaster. And there are umpteen examples of that.
I thank you for raising the issue of decolonizing global health, which is very topical, hugely, hugely important. It was an issue I was going to raise as this discussion goes forward. So appreciate you bringing that up. We're going to continue talking about the role of academia, NGOs, and societies and where they shouldn't go. I'm going to ask Mauricio from the perspective the Latin American experience, where shouldn't these organizations try and engage?
Yeah, thanks, Arian. First, I want to talk about the previous question about in Latin America, most of academic institutions think that the people from the NGOs may come to the region to do research or any other activities and then abandon the region. And we need long-term alliance must be created, lines of research, and we need a work in the time for the students and the local investigators and people who does research can work in our regions. When we talk about global surgery or global health, we try to think in other countries they have the problem. But in Latin America, we don't need to go to another countries. In the same city, we have some places we need all the strategies of the global surgery for working in research and create the baselines. That's my point.
Thanks, Mauricio. Anil? What do you see as areas that NGOs such as NSI shouldn't stray into?
I think, like Dr. Kokila had said, most of the, we were very lucky, and our NGO, we were very lucky that we had a donor from the States who gave us, I mean, that was in 2006 when they started it, who gave a blank check and a blank piece of paper. So it was left to the Nepalese people here to decide where and how the money should be spent. I think that led to us to start very slowly. We started with anesthesia assistant, like the non-physician anesthetist. Then we went to hospitals. And I think that helped us a lot. Whereas these big INGOs and bilateral organizations and all that come, that's huge in Nepal. They give very little, importance to surgery. For example, just an example is like our health budget is around 4% of the annual overall budget, 4.5%. And out of that health budget, the INGOs spend more than 12% of the actual health budget. So that's a huge amount. But out of that, so little goes into actual curative health because they feel that public health is, or the preventive health is more important. So to make them understand that surgery is a public health issue I think that's very hard for us to really impart and make them understand. So I think I fully agree that we should not be going along as NGOs as what they do like in Nepal. Most of them are in public health, in let's say WASH or vaccine or those. Okay, that's important, but they have neglected the curative aspect. So surgery has not become a big, let's say, big player in the NGO sectors in Nepal. So I think that's my agreement is that we should not now go along with the big, where all the NGOs go and go where it's needed.
Thanks, Anil. I'm going to switch topics just a little. And as we've touched on in a number of places, academia and research, I want to explore that a little more. And then we're going to go to the other topic, which has come up in the Q&A and in some aspects of this discussion. And Aaron is going to lead a little discussion on the finance aspect, which are crucially important. But I want to pick up on the theme of academia, research, high income, low income interface, and phrase the question of how do we turn that research into actionable items? Because one of the problems is that, as already explained, groups fly in, do some study, engage a few local people in being the workforce for the study, publish it in some prestigious journal, and then what? I go ahead with my nice promotion at my university because I got an article in the Lancet, but what have I left behind? So question, and I'm going to start with Albin. What are your thoughts about how does one make that research that's done in country an actionable item that can be used for political purposes, if you will, to enhance the NSOAP process? You're muted, sir.
I think I understand the concept of decolonization, but I think it's the NSOAP program should be looked at its entirety with regard to partnerships. What countries in middle and low income groups don't want is for somebody to come in, as you explained, do a study and then go. So the important thing is local participation and at a high level. So the research and academia from outside needs to actively engage the existing research and academia in that country. If I'm talking about my particular country, we are doing a lot of research ourselves. There are issues with funding, etc. And I think it's important with research and academia that you very actively look at local players in research and academia, and then you support them. So then it becomes a win-win situation. It's the same as the surgeons coming into Zimbabwe to do specialized surgery and coming for a couple of weeks and going. You know, that has its benefits, but what we prefer, certainly as a surgical society, is that there's partnership with the local surgeons. So we're looking at skill transfer and things like that. And skills transfer with regard to research is important. It's also important with regard to surgical practice and anesthetic practice. So it becomes a win-win situation for everybody. You know, we do have a small amount of surgeons compared to Europe, but some of the surgery that we are doing in Zimbabwe can be very, very sophisticated, and we understand that there's need for skills transfer rather than using a country as a conduit for research program that you have back at home. Thank you.
Thanks. I'm going to ask Dr. Alkak for what he sees as FIGO's role. I just say the WFSA does provide some small funding as incentives in country for research activity, and we have just embarked on a partnership with the International Anesthesia Research Society for research training fellowships. But they're actually quite surprisingly hard to get funded, and getting outside funders interested. Faisal, what's been the FIGO experience in fostering research and turning it into actionable items?
Thank you very much. I think the discussion, Adrian, should be, it's a two-level discussion. I think even the discussion on NGOs and decolonization has to be dissected more and more, but I think it's beyond the scope of this. So there is one aspect that Kokila mentioned, and that's a totally different aspect from another aspect of what we call the technical ownership. See, the nature of federations like FIGO or the WFSA or others is the kind of federation that's possessed by the local entities. It's not like something that's parachuted from Oxford or from Harvard or from somewhere else. We have an ownership in 132 societies. And in every national society that are in good terms with the ministries, in good terms with the rural areas, with every woman and every player in women's health. So these societies, they will generate needs from the grassroots level. And they will identify issues. And this is carried through a very transparent process to the federations and also to the to FIGO as a central leadership. And then application happens for funds. We're being lucky on aspects that really are there and obvious. You're talking maternal mortality, you're talking maternal morbidity, you're talking violence against women, you're talking issues that are concerning everybody from the SDG 2030 all the way to the most vulnerable, unprivileged women in the remote areas on the planet. At the same time, the type of research we're doing is also owned by the people who might be benefiting from the research. Whether this is an operational in terms of guidelines, operational in terms of changing practice, operational in terms of building capacities. We're now with the NIH on a huge work in Africa on menstrual health and menstrual care, and that's like very fresh, announcing it now. And we're trying as much as we can that all these activities and initiatives, whether they are research, to be translated into action, or it's a building capacity, it's all owned and generated by the national societies. And of course, more so in the low and middle income countries where FIGO is most needed. The American College won't need FIGO much, or the Royal College, but we know how to mobilize our resources to the most needed places in the low middle income countries. So I think we are more kind of a straightforward in that regard, because we are kind of technical / operational / service provision, which might a little bit vary. That's why I said in the question, from taking an NGO that comes in, and that's Alban, that's a classic problem for all of us living in low middle income countries. They bring in an issue, they come, they do some research, they publish it, and they go home. That thing should not happen. I think it should not be allowed. If any people from Oxford or Harvard coming to me and telling me I'm going to do research on the Syrian refugees in Lebanon, I will tell them, go away. We don't need that. I don't need that. I don't need that. I don't need to publish a paper in Lancet, although we have a Lancet Commission on the refugees, and they came to Lebanon and they spent 3 years. And I don't think any refugee woman in the rural areas of Lebanon, Turkey, or Jordan have benefited anything from these papers. It doesn't mean we shouldn't be generating knowledge. We should, and we are obliged to generate knowledge that are really very helpful to everybody. And that's our duty as academicians and as also a people of knowledge. We have to generate, but we have to at the same time generate a knowledge that's relevant and appropriate and operational and transferable, as Alban said, to those people. So in FIGO, we are very much aware of this, and we do our best to channel funds and research and its outcome to where it is needed much. I'm sorry I got emotional, but this is very important because Kokila touched on something very important for me, this whole issue of colonization using research, but that's beyond the scope of this panel. Thank you.
We love the passion.
Yeah, we live by passion, supposedly.
I'm going to hand the microphone over to Aaron to keep the discussion going. And I would just draw your attention, all of us, that there is an active Q&A ongoing with some discussion, some questions. So please have a look at that as well. Aaron.
Thanks so much, Adrian. And I think the questions around colonialism and research and treatment belongs everywhere, and certainly as part of this discussion too. So I'm really glad that we're engaging it as part of this discussion. I want to talk a little bit about financing, but first I want to talk about engagement with the ministries. Obviously, for all of us, it's essential that there's sincere ownership, that there's ongoing ownership, and that they really are taking the lead if we want to ensure the ongoing success of those programs. So I wanted to have a couple of you chat a little bit about what role the NGOs, the professional societies, and academia can provide in both supporting the ministry, advocating to the ministry, and to some extent potentially keeping them on task. I think it's really, really essential that there is some of that pressure from this community. So Dr. Abebe, if you wouldn't mind speaking first, you touched on your experience in Ethiopia. It would be great to hear your perspective on this.
Thank you, Irene. First of all, we must admit there is this distrust between professionals and ministries in this part of the world. Surgery anesthesia has been relegated, has been neglected for as long as we all can remember. So when ministries suddenly decide, then they say, we want to do a national surgical plan, nobody believes them. So professionals need to first understand that the ministries are probably sincere and probably take the step forward and start working with them. That's what happened in Ethiopia. It took about 3-4 years for professionals to even understand what NSOAPs meant, because there had been lots of NGO-led, ministry-led, surgery-related projects that kind of fell apart. Nobody remembers them anymore. So first, that bridge should be built. And the second, in fact, ties up to the previous discussion about research. If we demystify global surgery research, the outputs of such research are pillars for the development of NSOAPs. NSOAPs have 6 or 7 pillars, depending on which country you are. One of them is human resource for health, the surgical workforce. Data should be there in terms of what is the density, how many surgeons do we have, how many orthos do we have. This gives you an insight to the plan. How many should we produce and when? What is the burden of surgical diseases in the country? I completely agree with what Dr. Kokila said. Pediatrics was never in the agenda. It's only because there was no data and there was no one to vouch for it when planning was done. So one of the big responsibilities of academic institutions is to help ministries get the data, get the relevant data they can use to construct their NSOAPs and the financial risk protection, burden of diseases, delays in surgical care, SAO density, and others. This also ties to the former discussion we had about the roles of NGOs, what NGOs should not do. So far, academic institutions have not been empowered to take this role to help ministries. It's NGOs. They come to a country, hire their own people, set up their own system, generate the data, and use that data to plan. So NGOs should not work in silos. If it's research, if it's data, who is better than an academic institution to help generate that data? And the last thing I can mention is, at the end of the day, it's the professionals that implement the plan. You cannot talk about training surgeons without having the trainers on board. COSEXA is the largest academic institution as far as surgery is concerned in the continent, in the region, my apologies. 14 countries are part of COSEXA. At the moment, we have more than 600 trainees doing their 5 years training. COSEXA was nowhere in the picture when NSOAPs were considered in these countries. You cannot talk about, I am going to produce X number of pediatric surgeons in 2025 without convincing the trainers. You cannot talk about reducing your backlog, making surgery accessible to the poor without involving those who give actually the surgical care. So involvement of the professionals during the planning and the implementation is critical. In some instances, it's the professionals that actually write the plan, that actually sit in front of a laptop and type the content. It's the professionals. So having the plan done by an NGO or a consultant and handing it over to the professional would be wrong. I can be bold enough and say, I can say it's wrong. So that is what the associations and professionals can do to NSOAPs. Thank you, Irene.
No, thank you so much. And you've touched on this twice. I think it's such an important point is the ministries are going to obviously own this, but making sure that we have the right people at the table to guide this discussion, to inform the discussion. It seems really essential, whether it's pediatrics, whether it's all the key stakeholders in the country. Dr. Chu, if I can go to you to hear a bit about your experiences in SADC and in academia.
Sure. So, I mean, I think that academic organizations, universities can provide a lot of the data, facilitate, support, sensitize the Ministry of Health. But I think, for example, in South Africa, may be slightly different than Ethiopia. The Ministry of Health, it's not their idea so far, and they're not leading it. And I think that academic institutions, particularly in South Africa, we are at the moment more enthusiastic in sort of leading the Ministry of Health by hand. But I think similar to what Kokila mentioned about high-income organizations and international NGOs, you can lead as the Ministry of Health as much, they could lead a horse to water, but they'll have to want to drink it. So you actually need to walk that fine line where Ministry of Health actually has to take ownership of it. And I think that's really important in terms of financing, because in the ultimate end, I think the Ministry of Health, and then for us, Treasury, so the Ministry of Finance, actually needs to pay for it. Because if they don't, if you have, as nice as Anil, like a donor with a blank check to finance your NSOAP, the Ministry of Health is never going to take ownership of it. It's going to feel like, oh yes, that's a Harvard thing, or that's a Gates Foundation thing, but it's not actually part of our national health plan, which means when it comes time for implementation, when it comes time to allocating the right staff to the district hospitals so they can also perform a basket of surgical procedures, the ministry will say, well, that's not our plan. Our plan is HIV and TB. That's something the private donors are doing, which happens a lot, I think, in low and middle income countries. There's a lot of parallel things happening. So, I mean, I feel like academic institutions, local ones like ourselves, still may become as guilty as international groups in trying to do everything. And I think there's also a lot of tokenism, like we have getting a token Ministry of Health person on board, an international NGO coming in saying, well, we did ask the locals and we do have local partners, but I really want people to ask themselves, how much do those local participants really do? And how many skills did they learn, so that when you walk away, that they can actually implement this plan and they actually know what's going on, as opposed to just signing their name to it. Because I think that is the first step in decolonization. Yes, getting locals involved, but actually having them to be equal members at the table, I think we're far from that. And I think even as local academic institutions, we may be pushing our ministry harder than they want to be a part of. And that's right now translating into the lack of financing as well, because they haven't taken ownership. So.
Yeah, you make such a good point. There was a question in the chat about are there innovative NGO financing models we can do? What, how can we bring this to fruition? And you're absolutely right that there's a risk if it's NGOs or academia or others stepping in to fund the development process, that when we get to implementation, there won't be the investment or the skin in the game to really move this forward, because the development of the plan is obviously an important step, but then there are significant costs, obviously, and associated with the implementation, much more significant, and that ownership is really essential. So that's a great perspective. Mauricio, if I can go to you briefly to chat about your experience in Latin America and Colombia.
Yes, I completely agree that it's our role to make the Minister of Health include the data collection into the national agenda. As you know, what is not measured has the risk of being perceived not to exist. And the national health plans often contain little or no mention of surgery and anesthesia indicators. For policy planning, just for clinical governance, was it no measured, maybe no plan for, or management proactively? Where there is a metric, there can be a target set to monitor system performance. And I think our role as academic institution and as a national society of all the specialties is stay in that kind of tables of the Minister of Health and working as consultant with them.
Fabulous. Thank you so much. And Kokila, I'd like to go to you next to ask you to speak a little bit about your experience with NGO engagement in Tanzania and how, how the NGOs transitioned to really ministry ownership there.
So, and I'm hearing a lot in the platform that, you've got to get government engagement, and maybe the atmosphere right now, it's correct. But I have an association with Tanzania for the past 20 years. And I'll just mention a model of what has worked in Tanzania, where the local hospital asked for support in developing children's surgery in their local hospital. And I worked with my general surgery colleagues over 20 years just to develop the skills in children's surgery, because it's easier to train surgeons than to start from the beginning. And over 20 years, we have, where there were no pediatric surgeons, there are now 12 in Tanzania, just from skill sharing, so are able to do children's surgery. 6 of them are pure pediatric surgeons and 6 are doing part pediatric surgery. But with this interest, more of the NGOs became engaged. So Kids OR came on board and put up theaters for the group of children. And then there was some input from Smile Train and from Operation Smile on the cleft surgery in Tanzania. So there was some cross-fertilization of that happening. So there was NGOs coming in. And then the university got interested to say, oh, children's surgery is happening in our country. So they've developed a master's program. And at this point, the ministry got involved and became interested in saying, okay, we have surgeons now, we have NGOs helping with the infrastructure, and we have academia involved. The next phase, which was just last year after 20 years, where the ministry got involved and decided that they will support 4 centers of pediatric surgery in the country and provide support and infrastructure for that to develop. So it's just a model that can succeed if you start from the ground slowly, but this was pure local engagement. And the additional factor is that I've also engaged a primary healthcare specialist to work with the surgeons to conduct research, so that there's that sharing of a busy surgeon with a primary healthcare worker and global health worker working together on the same platform. So at the moment, the research output for children's surgery is really high because of local input by local public health specialists and surgeons working together. All I did was just support it and catalyze it.
Yeah, thank you so much. And there's an incredibly active chat and Q&A taking place that's touching on so many of these questions and issues. One was asking the group to speak about, have NSOAPs been more successful when the initial buy-in came from professional societies as opposed to the ministry, or vice versa? And I think it's a really fascinating discussion, because it seems that having the engagement of the ministry is obviously essential, and as Dr. Chu pointed out, having their buy-in and their investment from the earliest stages so that it's something they own and have some skin in the game is obviously essential. But then having the right voices at the table, having the NGO engagement and that advocacy taking place from all of these groups, obviously having academia driving the indicators and providing that linkage is really essential. Adrian, I'll pass it back to you now.
I was going to come at the question in a slightly quirky fashion, perhaps, and just perhaps it's just an editorial comment. Healthcare in democracies is a political issue. And where we seem to fail as a community of perioperative caregivers is engaging the public, and that has come up in the Q&A area and in some of the comments that have been made. And it seems to me, if we were as good at reaching the public, and for the public to demand of their politicians that they address this huge gaping hole in healthcare, that we'd actually get some momentum and engagement from the politicians, rather than us from high-income countries or leaders in the countries themselves, which is preferable, saying, we got to do this, we got to do this, we got to do this. And my concern is, how do we as a community reach the public and get the public pushing the politicians? And I don't know, Faisal, do you want to speak to that? And then Alban, what's been the experience in Zim?
I was reading on Gramsci reflection on the COVID and inequality, some of the analysis based on Gramsci, the famous Italian sociologist. And I think until, if we have not learned that COVID-19 have shown and laid barren our healthcare systems, and also have shown the defects of our democracies, which means we have not learned anything. I think COVID-19 have emphasized the gaps, have shown the inequalities, and also have shown that this whole biological biography continues to be dominant over other biographies in our community and society. So unless we push forward to see that the healthcare issue is in the top of the political issue, as you said, at the core of politics, then we will continue to pay the price of inequalities and marginalization and low funding and low finance and stuff. It has to come from the communities, in addition to the other players like we are here, what we represent, and other partners, to really force health systems and health issues and health policy to take top priority in the political programs, competition, and so on and so forth. And I think, and I hope that governments, especially those in whether they are the fragile health systems or governments in the first world countries, I hope they have learned that they have to remobilize their funds and they remobilize their resources after what happened in the scandals of COVID-19. Thank you.
Dr. Bowers, what's been the experience in Zim and perhaps more broadly in the region in trying to engage the public and turning perioperative care, surgical care into a political issue? You're muted.
I think there's two ways to look at it. I think it's quite important to attack this from two areas. I think one of the areas which might be easier is to convince the politicians of the importance of good healthcare. Population is much less restive and much happier in countries where there's a good health system. So one of my approaches would be to try and educate the politicians first as to the importance of good healthcare. If you go to the rural areas in Zimbabwe, if there's a well-functioning clinic in that area, the politicians need to understand that that's a huge feather in their hat with regard to getting re-elected. And some of the politicians here use that as an election tool. But I think it needs to be done on a more global attack on trying to get the politicians to understand the importance of health. If you look at in Zimbabwe, for example, our current health financing is 6% of budget, which is way below the Abuja declaration of 15%. So there's a fundamental issue with where health is put onto the political agenda. And the second thing I'd like to suggest is that one of the things that I would like to put forward is to try and change the Ministry of Health's focus. If you look at Zimbabwe in particular, over the last 20 years, it has had several previous programs which have been funded by the WHO and World Bank and some of the big institutions with regard to other health issues like TB, malaria, HIV, maternal and child care, and recently the COVID pandemic. And all these programs have been extremely successful in this country. Our HIV levels dropped dramatically, our TB levels have dropped dramatically. So given the correct focus, and that sometimes has to come from the clinicians, as the previous speakers have said, is to provide the ministry with the correct focus with regard to where their funding and their efforts need to go. And I think the NSOAP program is a very good platform on which that focus can be achieved. And I think it's quite important that we go through those 6 component frameworks that the NSOAP has done so that you can produce data that you can then give to the politicians to allow them to see the importance, particularly from 2 aspects, politically and financially to the country, of having a good surgical service. I think at the same time, which is a bit more difficult, is to try and get public educated on the importance of surgical services. Thank you.
Thanks. Dr. Shrestha, what do you see, what has been the experience of NGOs like yours in terms of engaging the public in the healthcare need as a national need?
What we've done is, first of all, listening to all the panelists, yes, there is a need for engaging everybody. But in Nepal, what we see is there's a huge gap between the rural and urban area. We have the workforce, but then there's nobody going to the rural areas. So what we've done as an NGO is we've utilized the government hospitals. We haven't built our own hospitals, number 1. Number 2, we utilize the government doctors and nurses and other workforce. The only problem there is what we've done is we've also engaged the hospital development committee that's formed by the local people. So we are constantly in touch with them to see what the needs are, because I think the people in the center or in the provinces, they do not understand fully how the thing works at the hospital. So one of our big role as an NGO is to engage these people who are there, who are I mean, what you call the hospital development committee there, the district hospital development committee. So engaging them completely in the process of developing the hospital to see what the needs are and how it's being fulfilled. So I think engaging these people is equally, I would say, or more important than, yes, we should be concerned with the Ministry of Health and other people, but engaging with these local people are very important. And what we've seen is that gives us a bigger result than maybe talking with the ministry people.
Thanks, thanks, Anil. I once again just draw everybody's attention to the Q&A, where there is a very dynamic and interesting ongoing discussion in parallel to the panelists. One of the themes I see in both the panelists' comments and in the Q&A that relates to money is my professional status in the NSOAP, my remuneration within the NSOAP, and how we address the rural service needs. And one of the common problems is the moment we talk about how are you going to compensate us for the work we do, and I'd say us as in all healthcare providers in perioperative care, that's physicians, non-physician providers, nursing providers, and others. Politicians' instinctive response is, you're just greedy and selfish. But it is absolutely fundamentally important that people feel valued. And that value isn't always about money, but the monetary value and job security are important. So I'd be interested in hearing from the panelists who've been involved in developing NSOAPs, how they've addressed that issue. And I'm going to start with Mauricio. What has been the experience, for example, in Colombia? And then go to Dr. Bekele for his experience with NSOAP in both Ethiopia and Rwanda. Mauricio?
Yes, Adrian, excellent question. I think we need incentives different from only economical. And we need to protect our most valuable resource, that is the healthcare workers. And the important thing is, in that kind of incentives, is try to give healthcare workers safe working environments and well-being programs. We have a lot of colleagues that prefer to go any place to work if they have their safe working environment and the well-being programs, and the economical is not the important point. Other aspect is the safety, because we go to very unsafe regions, and if we can provide safe places to stay to that health workers in that areas, they are very valuable for them. And I think that is my point about incentives in our region.
Thanks, Mauricio. Dr. Bekele, what's been the experience in both Ethiopia and Rwanda?
Yeah, thank you, Adrian. Unfortunately, NSOAPs rarely touch upon compensations and salary for healthcare professionals. I think this is why I see 3 or 4 comments in the Q&A that professionals are leaving the profession, no more interested in continuing to serve. This is because in most countries, salaries of healthcare providers are decided by parliaments and cabinet, who do not see the relevance of these professionals as really important. Professionals are just expected to deliver, but compensating them is not in their agenda. The commonest question parliamentarians pose is, how productive are you? And I still cannot find the answer to this question. How do you value the life of one pregnant mother? How much is that worth? How do you value saving the lives of 10 kids? How much is the revenue? I just can't answer that. So that's the language politicians understand. So unfortunately, salaries and incentives were not part of the Ethiopian and the Rwandan NSOAPs. However, a certain degree of support is considered, like healthcare, vaccinations, professional development, residencies and fellowship programs as part of the HRH development program, the SAO development program, and so on. But that remains to be a huge question in this part of the world. Thank you, Adrian.
Thank you. We're just about out of time, although judging by the Q&A and the discussion with the panelists, we could probably go on for many more hours. And I think the discussions will go on. I'm going to ask my colleague Aaron for a few sort of summary comments. And from myself, I think my take-home messages are that we need to find better ways of engaging the public. And on the point that Dr. Bakeli just made about politicians want a monetary value to life, the public doesn't see it that way. And I think the way to engage the public is with human interest stories, sad as they may be, where the system has failed to some extent without portraying the politicians who hold the purse strings in a bad light. And the other important take-home message re-emphasized for me is that engagement of the people on the ground is absolutely important from a research perspective. There's no point researching things of no relevance to the people that you are trying to engage with. And that in putting the studies together, it needs to start with a discussion on, is this question of value to you and your country? An issue we didn't really get into was metrics on how you know what you need to address and whether you're making an improvement. So I would just put in a plug for it's absolutely crucial to collect data in order to know what to fix and then to know whether you've fixed it or not. Erin?
Yeah, I agree with all those points. I think having data to understand the success, to be able to apply different value metrics for whomever your audience is, and to really be able to engage broadly is essential. And to do that in a way that engages local communities, that avoids the approach of HICs taking an active role and really ensures local leadership and that it's being driven locally, both obviously at the ministry level, but with really the right players and stakeholders at the table. I think having that engagement and that right mix of participants from the beginning is going to be really essential. The other thing that I think has come up in the chat and otherwise is breaking down the silos that we currently see between a lot of these groups. I think having that trust between the ministry, the professional societies, academia, and the NGOs is really essential. Having these voices all be at the table from the beginning and really ensuring that engagement and participation is set up for success from the very beginning is really important. I think the role that these groups play is essential. I say that being a part of one of them, as all of you are, but you know, so much work is happening and there's so much perspective to what the citizens need, what the country needs from these groups, what the professionals need, what the motivations are, that making sure we can have open discussions and have the right people at the table and break down those silos is really essential. And all of you have an important role to play in that. So yeah, I think it's been a fantastic discussion. And I'm so grateful to all our panelists, to WFSA and FIGO to Johnson & Johnson, to Unitar. It's just been a really wonderful discussion. Jeff, I don't know if you have any closing comments you'd like to give.
Yeah, thanks, Erin. This has been a fantastic discussion with a lot of passion, a lot of good points. I think really it's been so good. We're going to have to arrange another one like this to carry on this discussion. You know, I've just been jotting down a few of the really important points. And one thing that you just mentioned, Erin, was about the data, the metrics. And Catherine had mentioned that a really important role for the academic centers is to provide baseline data. So that's an obvious one there. Baby, you had mentioned the NSOAP needs a champion. I mean, that is such a true statement. We need to find the champions in our countries to drive this forward with all the stakeholders involved. Kokila, who had to drop off the call already, she had said, you know, the differences. She highlighted this difference between the high-income countries and the low-income countries. And I really want to emphasize this point. Who needs to be leading the process? It has to be the people on the ground who are facing those challenges. And one of the questions in the question and answer showed the difference between urban and rural, like you mentioned, Anil. And a lot of times, I think the challenges are different even between the urban and the remote rural areas. So we need to let the rural groups lead the process in their setting as well. So, you know, and then the research questions should come from the host country and not necessarily from the high-income country academic centers. So are they leading the process? Who is leading this process? And then we bring everyone together, the anesthesia providers, the different specialties, pediatrics. There was a strong call. Why isn't pediatrics involved? You know, if we all come together and include everybody, that's what will make the difference. And I think, Baby, you had mentioned, if we leave anyone out of this process, it's not going to be as good. That's something that we all need to remember. So on that note, I'll say thank you to all of our panelists. This has been a fantastic session. And on behalf of Unitar and the Global Surgery Foundation and the Program of Global Surgery and Social Change at Harvard, and all of our sponsored WFSA, Smile Train, FIGO, and of course, Johnson & Johnson, who've sponsored the whole series. I want to say thank you to all the panelists and the participants for taking part in this. And don't forget, there's one more session. It's January 13th. Go to our website, and it's going to be a very interesting session. And I'm not sure we'll be able to top this one.
You have to remind us. You have to remind us about it.
Yes, we'll send out reminders. Everybody who has been registered will get a reminder about that session. So
stay safe, everybody. Happy New Year.
Thank you very much. Take care, everyone. Keep safe, and Merry Christmas and the holidays.
Bye-bye.
Bye-bye.
Bye.
Thanks, everyone.
Bye, everybody.